I hereby open this academic ceremony in which Ms. Manetti will defend her academic thesis, Virtual Patients, Real Data, Exploring Mechanistic and Therapeutic Advances in Heart Failure through Virtual Patients and Cohorts. I welcome you and wish you lots of success together with your parnymphs. I, of course, welcome your supervisors, Professor Liewens, Professor Delhaas, and Dr. van Osta. I also welcome the opponents, whom you will meet later, and, of course, family and friends on site and online. But before we start the opposition, I give you the opportunity to tell your family and friends what your thesis is all about.
Yes. Eccoci, okay. Hello. Dear Prorector, thanks for the introduction. Dear members of the Corona, dear family, friends, and colleagues, and also for the people watching online, thanks for coming here today. It really means a lot to me. So in the next 15 minutes, I'm going to give you an overview of what I've done during my 4 years PhD. So let's start with the fact that cardiovascular disease is the #1 cause of death globally, with more than 20 million deaths occurring each year, and more than 500 million people are currently living with cardiovascular disease, which actually includes different types of diseases, and here we have a few examples. We have coronary artery diseases, arrhythmias, heart failure, and stroke. In this presentation, I'm going to focus on heart failure, which is a clinical syndrome in which the heart can't pump enough blood to meet the body's demands. So we can see it as an imbalanced scale, where the body's demands is much heavier comparing to the heart's output. Worldwide, more than 50 million people are currently living with heart failure. And in the clinical setting, patients are usually grouped according to common characteristics. Then, for each group, a standard treatment is provided. However, not all the patients respond positively to the therapy. Indeed, we have that some patients have no effect, meaning that there is no change between the before and after treatment, and some other patients have an adverse effect, meaning that actually they get worse after the treatment. But why is this happening? One reason could be that when we are grouping according to common characteristics, we are overlooking the individual differences and therefore the population variability. But also, when we use standard treatment, we are just relying on default values, meaning that we are not optimizing the therapy depending on the patient that we have in front. But what do I mean with common characteristics and individual differences? Common characteristics are all those observations that we can obtain in the clinical settings, and those are the effects, the why, and what we can see. And the individual differences are all the hidden properties, so what we cannot see. And if we use as an example the heart, this could be when the muscles contracts, and therefore the time of activation, how strongly the muscle squeezes, so the contractile function, but also how easily the heart feels, tissue compliance. And these are just few examples. And these are the causes, so the X, and therefore we have the effects and the causes, and we can use mathematical models to relate them. So the effects are function of the causes and the time. More specifically, we can use computer models to do that. And in this thesis, I use a circuit model of the human heart and circulation developed in Maastricht University. It provides real-time simulation of pressure, flow, and volume. It's based on physics and on physiology. And if we integrate population data, it's possible to generate virtual patients and virtual cohorts. Virtual patients represent the phenotypic diversity of a population, while virtual cohorts are a group of virtual patients obtained from real-world population data. So if we go back to the flow that I showed you before, we can actually improve this by using virtual patients and virtual cohorts. And this is the goal of my thesis, the one to use virtual patients and virtual cohorts to address the critical challenges of patient selection and therapy delivery in heart failure treatment. This type of approach can be used to different types of heart failure, and in this thesis we chose as clinical use case patients with heart failure and electrical desynchrony undergoing cardiac resynchronization therapy, CRT. The reason why we chose these patients is because they're really complex. They have mechanical problem and electrical problem. And before going into the details of the pathology, I'm going to give you a few basics about the heart works. So the heart is a pump and is composed by 4 chambers, 2 atria and 2 ventricles, and the wall between the ventricles is called the septum. The heart has 2 functions, the systolic function and the diastolic function. Systolic function is the one to contract and to eject blood to the system. And this is possible when we have that the muscle is strong, therefore we have an effective contraction, and therefore we have the sufficient output. Instead, the diastolic function is the one to relax and get filled with blood by the atria, and this is possible when the ventricles are compliant, so we have a good filling, and therefore we have a low filling pressure. In the case of heart failure, this changes. In this, we could have systolic dysfunction, and this happens when the muscle is weak, therefore we have a weak contraction, and so we have a reduced output. But we can also have diastolic dysfunction, and this happens when the muscle is stiff, therefore we have an impaired filling, but also an elevated filling pressure. And this is for the mechanical problem. I also mentioned the presence of electrical desynchrony, but before I'm going to give you an overview about the normal electrical activation, because the heart pumps and contracts thanks to the fact that there is an electrical signal that starts from the right atria and then goes simultaneously to the ventricles, and then the ventricles contract. This electrical signal is recorded as the ECG, and in a normal situation, we have electrical synchrony, but we also have mechanical synchrony, because both ventricles are contracting at the same time. So we can see the ventricles as rowers in sync. In the presence of electrical desynchrony, such as left bundle branch block, LBBB, the signal always starts in the right atria, then goes to the right ventricle, and then it goes to the left ventricle. So we have a change in morphology in the ECG, so we have electrical desynchrony, but also mechanical desynchrony, because we have first the activation of the right ventricle and then the left ventricle. So ventricles act like rowers out of sync. So when a patient comes to the clinic and he has electrical desynchrony as a change in the ECG morphology and also reduced pump function, he's eligible for CRT, which involves the use of a pacemaker, and the main goal is the one to resynchronize the ventricles. However, not everybody benefits from the therapy, and this could be due to patient selection or therapy delivery. And as I mentioned before, the goal of my thesis is the one to address the challenge of patient selection and therapy delivery. Here it comes the content of my thesis, where we generated virtual patients in Chapter 2 and Chapter 3 for mechanistic studies in CRT patient selection and CRT optimization. Then in Chapter 4 and Chapter 5, we generated virtual cohorts for training AI models in patient selection, but also for performing in silico CRT trials. For a matter of time, in the next slides, I'm going to show Chapter 2 and Chapter 5, also to give you an overview of 2 different types of methodology that we can use to generate virtual patients and virtual cohorts. Chapter 2 comes from a close collaboration with cardiologists from Hasselt in Belgium and from Maastricht. They retrospectively analyzed 290 CRT candidates, so they look at the data before CRT, so before the implantation of the pacemaker. And when they divided the population depending on the value of filling pressure, so low and high filling pressure, they noticed that in the group with low filling pressure, there was high mechanical desynchrony, while in the one with high filling pressure, low mechanical desynchrony. And then, when they look at the data after CRT, so after the implantation of the device, they noticed that in the group with low filling pressure and high mechanical desynchrony, there was good response to CRT. While in the other group, high filling pressure, low mechanical synchrony, non-response to CRT. So we have these 2 types of measurements, filling pressure and mechanical desynchrony, and now the question is there a link between these 2 measurements? So to answer this question, we used the CircuitOut model, and we generated a set of virtual patients that wanted to represent the phenotypic diversity of the population, therefore with low filling pressure and high filling pressure. And to do that, we changed the following input parameters with elevated electrical desynchrony in both, since this is a type of pathology that we are dealing with. Then we preserved the contractility in order to get low filling pressure, and we decreased the contractility in order to get high filling pressure. Then we also changed the stiffness of the left ventricle, and it was kept preserved in the low filling pressure case, and it was increased in a high filling pressure group. Then, when we calculated mechanical desynchrony in our model, we noticed that, as in the clinical data, in the group with low filling pressure, there was high mechanical desynchrony. And in the other one, instead, there was low mechanical desynchrony. And now we know that the component, like the two factors that are influencing this relation, is the presence or absence of contractility and stiffness, so the increase or decrease. So now we know that there is a link between the mechanical desynchrony and filling pressure, and actually what we have is an inverse relation. Because in the case of high mechanical desynchrony and low filling pressure, what happens is that we have a not elevated stiffness. Therefore, if we look back to the metaphor of the rowers, the one that was out of sync simply for a problem of time. But however, he was healthy and strong. So by the time we apply the pacemaker, we're actually able to fix this problem. And therefore, we can expect good response to CRT. Instead, in the other case, this happens like when we have high filling pressure, is that this is due to the fact that we have an increase in stiffness. And so if we look back to the rowers, the one that was less out of sync, so we could have thought that was better. Actually, this one was less out of sync due to the fact that it was stiff, not healthy, and tired. And so even if we apply the pacemaker, this won't change. And so we have a less response to CRT. So we can conclude that the presence of mechanical desynchrony in patients with electrical desynchrony, such as LBBB, indicates a favorable substrate for CRT. So if we look back to the flow that I showed you before, we could actually improve the selection of candidates for CRT if we could include as measurements for assessment of eligibility the presence of mechanical desynchrony, because now we know that when it's high, the patient will benefit from CRT, and therefore we can improve the patient selection. But now the question is, can we reinforce these results in an in silico trial? The answer is yes. However, we need to change the type of methodology to generate the virtual cohort. Because in chapter 2, what we did is that we generated a set of virtual patients that wanted to represent this phenotypic diversity of the population, so low and high filling pressure. And this was possible by changing the model input parameters, even though this approach is really useful for mechanistic studies and for making a hypothesis. If we want to generate an in silico trials, we also should take into account the population variability and therefore the individual differences. And to do so, we follow a different approach. So we consider the data from the 290 CRT candidates, so without dividing them in low and high filling pressure, and then we consider the probability distribution of the clinical measurements. And then also for the model input, we consider uniform distribution. Then we use Bayesian inference, which help us to update our knowledge about the model input parameters by looking at the data. So, for example, if we start from the model input and we get one value and we give it to the model, then we get one model output, and then we can compare this model output to the probability distribution of the clinical measurements. And then, depending on how close we are to the clinical measurements, we can update the input space. Then we can do this until we are satisfied and until we meet criteria. And then what we obtain is a virtual cohort where we can say in a more confident way that it is able to capture the population variability that we have in the data set. Then we applied a pacemaker virtually, so we simulated CRT by presynchronizing the ventricles. And then we defined a response criteria that allowed us to divide the population depending on the level of response. Then in the further analysis, we focus on virtual patients with high response and with higher response and lower response. And what we notice is that by looking to the data of this virtual patient before CRT, the patients with high response were the one with high mechanical synchrony and low filling pressure, while the one with low response with high filling pressure and low mechanical synchrony, as it was in chapter 2. So we can reinforce the fact that the presence of mechanical synchrony in LBBB patients indicates a favorable substrate for CRT. So to wrap up, I show you how to generate virtual patients which want to be a phenotypic representation of the population. And they help us also to understand the link between filling pressure and mechanical desynchrony. And we understood that the role of stiffness and contractility was crucial. Therefore, we were able to understand the underlying tissue characteristics. So we can use virtual patients to understand and to get a valuable insight into the underlying mechanism of heart failure. Then I also show you how to use virtual cohorts and how we can use them to generate in silico trials. And we were able also to get the same heterogeneity in the response as in the clinical data. So we can say that virtual cohorts capture pathophysiological heterogeneity observed in real clinical population. And therefore, they can be used, we can affirm that they can be used for patient selection and for therapy delivery. And with this, I want to conclude, stressing the fact that in this thesis, we demonstrated that if we carefully construct virtual patients, they can generate real data, not just an approximation, but valid scientific evidence that can advance our understanding in cardiovascular disease and treatment. And I would like to thank you for the attention, and I'm going to give the word back to the prorector.
Thank you very much for an interesting presentation. We now start the opposition with Professor Geris, who is also a member of the assessment committee, and she is professor in biomechanics and computational tissue engineering in the Catholic University in Leuven, and is in Belgium. And thank you for coming all the way from Leuven.
Thank you, Mr. Prorector. Dear candidate, congratulations on an interesting presentation and read. I will start with some more general questions, and then my colleagues will go more into depth. I would like to start going all the way back to the start of your thesis, where you started from an established model with the CircAdapt model. If you could go back, would there be something that you would have wanted to see already present in that model, rather than now you had to work with it as it is? So looking back, was there something that you thought, if the model would have had that feature, that would have made my life much easier?
Highly esteemed opponent, thanks for the compliments and for the questions. I feel like CircAdapt is a really friendly model, also give the fact that he's really well documented. I think really it helps any type of researcher to deal with different type of problems, and also the fact that is 0D and also it's really fast and is made of modules really help you to decide which type of module you want to change. For example, if you want to simulate stenosis or regurgitation, you can do many different things. And also the fact that it gives realistic hemodynamics, but also strain and stress, so also the deformation of the segments. I think it made it a really good model, and for this type of study, I think it was a really good choice, because especially as I mentioned in the discussion, indeed we have many different models, also the 3D, so they really give you a more realistic representation, of course. However, for the type of study that I did, I think that CircAdapt was on point. So I'm happy about the choice of the model for that.
Okay. Yeah. Then next I would like to discuss the context of use, which is, if we are taking the model further, it's very important to start with a very specific context of use, whereas in academic models we tend to build on and on and on. So it's not it doesn't start from a context of use. Do you see that as a limitation?
Well, of course, CircAdapt, I mean, it was built in the 90s, and it grew a lot. So I already came 4 years ago, so I could already see like that it was really much different comparing to 30 years ago. So I feel like it improved a lot, like also the things that we can have the septum and the LV free wall, and we can divide it in patches, therefore we have a better simulation if we want to simulate LBBB in the 18 segments model. So I feel like now for sure there is always room for improvement, but
Good.
Yeah.
Let me continue by asking one of your paranims to read proposition 5, please.
I'm sorry.
Patient-specific digital twins require extensive individualized data, making population-level virtual cohorts the only scalable approach for large-scale in silico clinical trials.
Thank you. Could you explain me, and especially around the scalability, how you interpret this statement?
So of course, let's start with the fact that digital twins, I think it's a really interesting technology, and indeed is going really well with a lot of type of studies and applications. The things that I understand is that digital twins indeed requires a lot of data, and by the time you want to generate a lot of patients, then it takes more time, and they are really precise, like really specific. So I believe that in population studies, such as the one that I show you in chapter 5, I think that if we want to generate in silico trials in large scale, that at the end I simulated for the CRT in silico trial 9,000 patients or so, I think that that type of number is something that will be, in my opinion, a bit difficult to get with digital twins, because it means that you need to have 9,000 data from the hospital and then generates a one-to-one comparison. So scalability, it can be also in the modeling perspective, but also in general, because we know how difficult it is to get the data from the hospital and complete, which is the key for digital twins.
Maybe on this, because you have a model that is, of course, predisposed to certain behaviors that are in there, and then you have data that you're using for a population. You mentioned somewhere in your book that you were able to capture the bulk of the behavior, but that there were some outliers in the clinical data that you were not capturing. So is that then not a risk that we overemphasize the patients that are the typical patients that maybe already have good treatment, and that the interesting cases are left out?
Yeah, no, that's, I agree. And indeed, I believe that the part where I do remove the outliers, I feel like some outliers, especially if then we use them for making inference, if we know that they're out of the bounds that we would expect, we should remove it because they're maybe not physiological. However, I feel like maybe some outliers were not meant to be removed, because indeed, if we remove the outliers and we are focusing just on the normal distribution, for example, then we are not giving enough importance to the tails. And maybe those are the patients that are more critical and that we don't have them often in the therapy, and the one that maybe need more attention. So I feel like probably there should be some improvement also for that, and maybe considering also those patients and see.
Okay. Yeah. Thank you very much. I give the word back.
Thank you very much, Professor Geers, for your opposition. Then we come to the following opponent, who's also a member of the assessment committee. It's Professor Voigt. He's professor in cardiology in the Catholic University in Leuven. And thank you for coming all the way from Leuven.
Thank you very much for the introduction, dear candidate. It was my pleasure to follow your presentation. It was very well done, and also to read your thesis. And it's also quite an impressive list of publications that you have, so congratulations for that. I would like to start with a question about your understanding of mechanical desynchrony. Of course, you use that a lot in your studies, and you explained it also in your slides very nicely with icons, with these rowers, which was very nice. There was a left and a right ventricular rower. Is that really the right way of showing it, or is it maybe a little bit more complex? Can you just explain how that is and how that leads to things like apical rocking and septal flash?
Yeah, highly esteemed opponent. Thanks for the compliments and for the questions. Yeah, absolutely. Of course, I would like to be more precise on the icon. Instead of placing the right ventricle, I should play the septum and the LV free wall. But for the presentation, I thought, okay, I'm gonna just stick to it just to make it more simple. But indeed, mechanical desynchrony happens in the presence of electrical desynchrony, and therefore we have first the contraction of the septum and then the contraction of the LV free wall, and this leads to the apical rocking, indeed, and therefore also the septal patterns that we know really well. But of course, this can change in the presence of low contractile function or increase of stiffness, where it looks like from the strain patterns that it's more synchronized. However, it's not synchronized because it's healthy, just because it's stiff. So it won't move and it won't react to the contraction of the septum, and therefore the LV free wall would just stay there without moving. So.
Okay, so if you have a heart failure patient with a with a left bundle branch block, you would expect that this patient shows the typical signs of a septal flash and an apical rocking.
I would expect that, but of course, the best way to understand it is to look at echo and understand the presence in the strain patterns. But this is something that we could expect if the tissue.
I would agree. I would also expect that, and I was wondering a bit about table 1 on page 28, where you describe your patient cohort. There you have a apical rocking septal flash negative cohort. With a wide QRS complex and a left bundle branch block. If I interpret that right, 35 patients that do not have apical rocking and septal flash. How can that be? Is there any explanation how somebody can have no rocking and flash?
Unfortunately, apical rocking and septal flash, it's something that might be difficult also to understand from echo, and also is binary, so it's yes or no. So I think also does have an influence on deciding if someone has a septal flash or an apical rocking due to the difficulty of seeing the images and seeing this movement. However, even though we could have LBBB and no apical rocking, because if we have a stiff myocardium, then we don't have mechanical synchrony, and therefore we would have a less pronounced apical rocking. But I do believe that since there is no a quantity of apical rocking, but it's something that is yes or no, I think it's, even though it's really practical
measurements
to get, it's still difficult maybe to assess. So.
I think this is one component. It's certainly the assessment of these things, which is subjective. I would completely agree with that. And that's maybe also the explanation when you look at your figure 3 and figure 4 on the next page then, that you have rather good responses to CRT in these patients without apical rocking and septal flash, which is rather unusual. On page 30 you have, I would expect that if somebody doesn't have these signs that this patient is doing badly, as bad as somebody who doesn't get treated with CRT. So do you see a relation or is it possibly an explanation that there's a connection between the reading of these things which maybe have gone wrong in some cases and these results? How would they change if you would detect more rocking and flash in your patients?
I mean, thanks for the question. And yeah, of course, when I was showing in the presentation, I was clearly showing the absence and feeling pressure, the presence or absence of mechanical synchrony and feeling pressure as black and white. However, the difficult part is that we do have a mix of it. And I do believe that maybe this not response being really low as we would expect also could be due to this, so a mix of factors that are actually playing a role. But again, the sad part of using echo is that it's difficult to assess. They bring a lot of noise and can be maybe also interoperator variability, intraoperator variability. So to improve that, maybe we should have also looked better for each patient at the septal patterns and also divide the population depending on septal patterns and see depending on that.
No, I think this. What I would assume is that if you underestimate rocking and flash, that you have an overestimation then on the CRT success, because they were indeed desynchronous, these patients, but you didn't see it.
Yeah.
We can only speculate, of course.
Yeah, but also about the response, in clinical trial in the silico, I use a spectrum for response. However, in the clinical studies, we use cutoff values, and I think also the cutoff values play a role in that. Could also play a role in that.
Another question which is related to myocardial function, you use this term of contractility a lot in your studies, and you're talking about reduction in contractility also in your model. Can you explain how you did that? Did you reduce contractility everywhere in the myocardium or at specific places?
Short answer, please.
Yeah, so in chapter 2, yes, we just look at the LV free wall and the septum. So when I was reducing the contractility and therefore the active force, so you have the sarcomere, it was in the whole LV free wall, and we can see them as like the sarcomere being stretched. So therefore they cannot contract forcefully. While in chapter 4, when I generate myocardial virtual cohort for in silico AI, then I focus on myocardial infarction, and therefore for specific segments of the 18 LV, then I change the contractility and the stiffness for each segment depending if there is myocardial infarction or not.
I have a lot more questions, but the time is over.
We can discuss later.
I have to give the word back.
Thank you.
Thank you very much, Professor Voigt, for your position. Now we come to the following opponent, that's Dr. Engineer Perlink. His expertise is computational cardiac biophysics at the Technical University of Delft. And thank you for coming all the way from Delft.
Thank you, Mr. Prorector. Dear candidate, thanks a lot for a nice book. I really enjoyed going through it, and thanks for a nice presentation. Due to my profession, I already see cardiac biophysics everywhere, but I didn't see it in rowing yet, so thanks for that. So yeah, in the group that I work in, we work a lot on Bayesian inference, so the likelihood of my posterior distribution of questions coming for chapter 5 was expected to be quite high, so I would like to start there. So in chapter 5, you've used Bayesian inference to learn about the virtual cohort and the parameters that you have. So if I look at some of the results of your work there, so in figure 2, for example, you had quite some parameters that you tried to infer, but quite some of these parameters in the end still show a uniform distribution. So I was wondering what's the added value of Bayesian inference there, in your opinion, given that they sort of stay stuck on the prior distribution, so what you already believe to be true.
Yeah. Highly esteemed opponent, thanks for the compliments and for the questions. Indeed, for example, in the contractility, which is yes a fact, so the first subplot, we have a uniform distribution. Therefore, what we can understand from that is that the parameter is not identifiable. So indeed, if I would start over the study, I would start first with a sensitivity analysis, of course, and that was already performed, but also an identifiability analysis, because indeed also when we look at the correlation matrix, we do have a correlation with contractility, and therefore it means that it doesn't add anything to the input space. So for example, we could remove the contractility and just change, for example, the FAC MRLV, which is basically the eccentric scaling factor, and therefore we have also the stiffness, and we have other parameters. So identifiability analysis will be the answer for your question.
Yeah, and I think then my second question is sort of connected to that. So you looked at the total Sobel order indices, right, for the sensitivity analysis? Yeah. And based on that, you selected these parameters to go for? Or these outputs? Yeah,
so basically what we did is that I looked at the parameters that was already used in a previous studies in our department, where they perform an extensive sensitivity analysis, and I considered those parameters because also in that studies they were looking at CRT patients, so that was the perfect list. However, for example, indeed, yes, a fact could have been left out. And they also, in that sensitivity analysis, they look at they did body screenings, Saltelli, so they did all the steps. Of course, if I would start this project, I will do the sensitivity analysis myself, but for a matter of time, I had to make choices. So.
Yeah. Yeah, but so then you sort of see the effect of that in your results, and that is also useful then for you to redo the test. Yeah,
exactly. Thank you.
And then maybe connected to that, so I saw you chose for the Metropolis Hastings method, but then you had quite a discussion on how to tune the hyperparameters for that specific algorithm. So I was wondering, would now, in hindsight, another sampling methods have been more interesting?
Yeah, metropolizing, I think it's really nice, especially because it's pretty straightforward. And for me, that was the first time working with Bayesian inference. I think it was really nice to use, and for me also to understand the process of Bayesian inference. However, it does have some lack, such as the fact that it really depends on the prior that you choose, but also the proposal distribution indeed. So what I would do now is, for example, performing the adapting sampling. So basically, I can also adapt the variance of the proposal distribution while I'm walking in the chain, let's say. So depending on the results that I get, then I can adjust the variance accordingly. So I don't make a strong assumption in the first place, but I make the model choose the best variance. That would be what I would do.
Okay, thank you. And then maybe as a final question, because of time, I have a bit more of a general question. So if I looked at table 1 of chapter 2, I saw that there was quite a male-dominated clinical trial.
Yeah.
And so, yeah, that sort of spurred my interest. So I wanted to look into literature a bit, and I saw there was some literature out there stating that CRT would be more effective in women than in men, but then other data sort of nuanced that. Did you see something similar in your results? And do you see any role for digital twins in looking at the mechanisms behind such a potential difference?
Yeah, gender difference, I think it's really key for this trial, for example, because indeed CRT, it looks like to be much more effective in women. However, we always have a more prevalence in men in the trials. But as one of the cardiologists that I work with, he told me that women, since this selection is also based on symptoms, I think it really depends how the patient react in that moment. So that's why maybe we don't have many candidates as women. However, I think the digital twins, maybe more digital twins indeed can help to understand if we parameterize the model depending on values that are more closer to the women body, then we could have maybe a better insight, and then we could compare to the digital twin men and see the difference underneath.
Okay, so there's still some role for education there.
For sure, yeah, the gender, because I never spoke about gender when I was simulating, so I consider like a patient X. However, we know that we are all different, also for the gender, of course, so yeah.
Okay, thank you.
Thank you very much for your opposition, Dr. Inge Perlink. Now we come to the following opponent, and that's Dr. Knakstedt. He's a cardiologist in the Maastricht University Medical Center, and today he has also accepted the role of secretary of this committee, for which I'm very grateful. The floor is yours.
Thank you. I would like to begin by congratulating you for this beautiful thesis and also your PhD by supporting you. Of course, I have a couple of questions, and I would like to start off with chapter 2 also. Probably as a clinician, I have a different point of view, because you stated nicely that high filling pressures carry a worse outcome. When I hear or see high filling pressures on the echo, I think of fluid overload. In the model, you changed, however, the tissue characteristics to induce LA filling pressures. Are we talking about the same issue?
Highly esteemed opponent, thanks for the compliments and for the question. Yeah, I think when we are talking about the fluid, we are talking about like the level of the lungs, and if we go backwards, then we arrive in the left ventricle, and then the left atria, and then we can go backwards. And therefore, what we simulated is the tissue characteristics, because that's what we can do in the model. And by changing the stiffness, by elevating the stiffness or reducing the contractility, we are changing the passive relation of the sarcomere. So what I'm doing is that I'm changing the slope, and therefore we are moving to the higher slope, and therefore we have higher filling pressure, which then would result in dyspnea and fatigue, and therefore fluid load. But that is something that I couldn't simulate in my model, but we can use in this model a surrogate of this MLAP, so mean left atrial pressure, filling pressure.
Okay, because what I usually do, I give diuretics, which of course decrease the filling pressures, but also change probably the dimension of the left atrium or even the ventricle.
Yeah.
When I look at the medication of the patient, of course it's somewhat clinical issues, but I get the feeling that those patients are undertreated because they don't have the usual four suspects of modern heart failure therapy, such as ARNIs or SGLT2 inhibitors. There's a low percentage of ACE inhibition. What those modern drugs do is that they decrease the blood pressure by decreasing the peripheral resistance. They, of course, get rid of the fluid overload. Could you model those effects in the CRT group?
Simulating the use of diuretics, yeah, we could we could simulate difference, like the decrease of pressure. However, in the model, what we can mostly do, that's the strength, is that we can change the properties of the myocardium. Now I have to think how we could also introduce this type of simulation, for example, the one if we want to simulate the medication. In my study, I focus mostly on the pacing part. However, since diuretics are really useful also to decrease the symptoms and the fatigue, and probably these patients were under treatment, I think that will be also something to consider and to see how it will differ with the results, for example.
Thank you. Right now, we are seeing a pretty high percentage of patients having cardiac amyloid disease, which is sort of protein accumulation in the extracellular matrix. So they get thickened and stiff heart because there's extra protein accumulation. There's some medication, but we are not sure what will be the exact response of a CRT in those patients. I couldn't find back any comment on left ventricular thickness or mass in the patient characteristics. Could you hypothesize on what an underlying cardiac amyloidosis would do with the effect of CRT?
Well, if you're talking about a stiffening and also an increasing of the wall, I would also expect. Okay, we haven't simulated that like one-to-one, like an increase of wall. However, since they're getting stiff, then I would also expect for them a less benefit from CRT. That's what I would expect after seeing the results of my model. Okay. But I should also simulate.
I have 3 more minutes left because we have to talk about the coffee issue.
Coffee issue.
Could somebody read out Proposition 10 aloud, please?
Real coffee does not need sugar.
Okay, I get the impression that you're a little biased talking about Italian coffee. We won't have it about Dutch or German coffee, that's awful. But I asked ChatGPT about the percentage of Italian people putting sugar into the coffee, and apparently the majority does it.
Yeah.
So that sounds like a more individual statement. Transferring that to the model you used, I also feel that is a little biased by Professor Loomis, of course.
He puts a lot of sugar, I'm sorry. I mean, he puts a lot.
Are there any models you're aware of, any other companies that have comparing things to offer?
I'm not aware of that. The reason why I made this proposition is that I think the sugar actually changed the taste of coffee, and also a lot of sugar is not good, and then also diet-wise. So that's why.
Okay, because believing in just one model as a clinician sounds a bit cumbersome. Or do we have? What is the future up to you? Do we have to? Apparently, there are a couple of models around there. Do we have to compare models when it comes to advising us as a clinician?
But sorry, about the coffee. Okay.
Yeah, I know,
because now maybe I'm not understanding the question.
The link was coffee as a subjective or an individual taste, right?
I'm sorry, I missed that.
The model use, which might also be quite individual.
I'm not sure about that. At the end, yeah, the model can be individual. However, we can understand population variability by changing the model input parameters, and therefore we can, for example, for the coffee, see also if we put the sugar or not, if it's like a model input parameter, how this would change, for example, the health of the person that we are looking at.
Thank you.
So.
I hand back the word to the supporter.
Thank you, Dr. Knakstedt, for your opposition. Now we come to the following opponent, who's also a member of your assessment committee. That's Dr. Engineer Bonizzi, and his expertise is biomedical signal processing in the University of Maastricht. Dr. Bonizzi.
Thank you, Prorector. So, dear candidate, also from my side, congratulations for your work, and also extend it to your supervisory team. I really enjoyed to read it. I do agree with your proposition 10, by the way. I think ChatGPT was hallucinating, which happens. By the way, I have some questions as well. My first question is about the synthetic data. So it's a very strong element in your thesis, in your work, right? And it's a very important topic, especially when it comes to medicine and healthcare, I feel. Especially when it comes to wanting to use AI in healthcare because of the need of training those models with a large amount of data. And, but when it comes to synthetic data, what happens is that we want to make sure that they are sufficiently similar to real data, but at the same time, we want them to be not too similar, right? Because otherwise they just become a replica and then they become useless because we are not really creating something, let's say, new to a certain extent, or with a sufficient variability. So somehow the tricky thing with synthetic data is to strike this balance between being sufficiently close to real data and not too close to real data. And what I missed a little bit in your work what is your systematic procedure to quantitatively assess whether the synthetic data that you're generating, when they are too close or when they are to a sufficient level, to a sufficient balance, so that you can consider them to be useful to be used for, let's say, the applications that you want to use them for.
Highly esteemed opponent, thanks for the nice compliments and for the question. Yes, indeed, like in chapter 5, yeah, the one when I'm generating virtual core with Bayesian inference and then for the in silico trial, the way that I use it was a soft validation because at the end what we are talking about is validation, how good are our data and then if they are too close or too far. What we performed was check for the representativeness of the population, and therefore we compare the data that we had, that we obtain with the Bayesian inference with the one that we have. We compared with the population distribution, but also with the relation, so with the correlation matrix. However, of course, we could also have the idea to consider another data set and make a quantitative comparison to that. However, I think what we will look is always, like, for example, the the probability range and see if they are in line with that. And in my case, except for the ejection fraction, which was a bit higher comparing to the normal CRT population, which needs to be lower than 35. All the other measurements were in line with the data that we have. So I feel like for the population that I created, this type of approach was a nice start. Of course, there is always room for improvement, and future study could also look for how to better validate the study.
I think you did well in trying to understand how realistic they were, how similar to real data are. And that's, when it comes to synthetic data, that's what we first try to do, right? But looking at how dissimilar they are, and still to a level that they are, let's say, physiologically meaningful, that's the hard part.
Yeah.
I know, and I understand. And I really wanted to have your idea about, okay, how do we actually look at the dissimilarity more than the similarity? Because we know how to look at similarity, but it's more the dissimilarity part that interests me.
Yes. Indeed. I think also something that while I was relooking at my thesis, I thought it would have been also interesting to not throwing out like the parameters, like the values that were not like in line with Bayesian inference, but maybe they were not out just for like a bit, and see how those parameters and therefore those outputs were were resulting, because maybe those are the ones that are more like dissimilar. However, they could also bring us more information, because indeed with Bayesian inference I'm trying to fit the distribution, the distribution of my data set. So I feel like an interesting part would be, if we follow this methodology, to look at those data and see, and yeah, now thinking about like a methodology to study, I have to think more, but I think like to start would be better to analyze them in the first place and not like discard them, because maybe those are the dissimilar that we are interested in.
Thanks. My second question was, actually I also had a question about figure 4 in chapter 2, but I think I like your answer to Professor Boyce, so I'm going to move to another more technical question. So I also, it's about chapter 5 and the Metropolis Hastings method that you use for Monte Carlo Markov chain. And you say that, as you already replied to another question, that yes, it's a method for high dimension to treat problems with high dimensionality. But one of the issues that is heavily influenced by the choice of the proposal distribution, especially with the variability. And I was wondering whether you could use a different approach, like why not first to transform your data so that you reduce the dimensionality of a problem to a lower space, like, for example, by principal component analysis, because can handle very well both the low dimensionality problem and the variability, so can still take into account the variability of the original data. And then doing your sampling in this lower space, which might be easier, and then simply take the samples that you generate and reproject in depth to the original vector space. Or, you know, what do you think? Could be an approach, or it doesn't make sense?
No, I think it does. It does make sense, because of course, even though we have 11 input parameters, there are still quite some. So we are not talking about few input parameters. So I think it will be wise also to reduce the input space. And also when you were talking about transforming, I also thought about the fact that giving a hard bounds for the uniform distribution, and that could also lead to some problems close to the edge. So another way of transforming the data, like the input parameters, is to, for example, put them in a log norm, like in a logarithmic way, so in such a way that we don't have any bounds, so we are free about the edge problem. And then I feel like also in this way we could then reduce them to PCA, and I think also this could improve the speed of the algorithm, because we have less parameters to sample from. So I think I haven't thought at that time, but I think it's something that could worth to be looked at.
Yeah, thanks. One last question? No time, no question. Thanks.
We can discuss later.
Thank you very much, Dr. Bonici, for your opposition. Now we come to the following opponent, that's Professor Huberts. And his chair is Credible Computing in Health in the University of Amsterdam, and he's also head of the Department of Cardiovascular Biomechanics in the University of Eindhoven. And thank you for coming all the way either from Eindhoven or Amsterdam.
Was Eindhoven, but thanks for the introduction. Dear candidate, first of all, I would like to congratulate you with the work. I really enjoyed reading it, but I also really liked it. So it's not only the reading that I like, but also the work that you actually did. But of course, I also have questions. And first of all, I want to get straight that I understand your virtual cohort generator completely. Because if I understood it correctly, you have 4 components. So first you need to do an input definition, input space definition. Then you have your model, which is in this case SIGADAPT, and then you have an outspace definition. And then you use some kind of inference method to learn the subset of the input space that gives realistic output realizations in the output space. And for both the input and output space, you need data. And that's where I want to start. And for that, I would like to ask one of your paranames to read proposition 4.
Virtual cohorts derived from sparse data can effectively represent the pathophysiological heterogeneity of heart failure patients, enabling robust in silico trials to predict therapeutic outcomes.
Yeah. Thank you. And I want to focus a little bit on the term sparse data. Because we all know that within a clinic, all the data is not specifically collected for a model. And we all know that it's always collected within a context of use, so you have some data provenance in there, and we have a lot of missing data. So what's your definition of sparse data, and how sparse can it be to still result in acceptable results of an acceptable virtual cohort?
Hi, esteemed opponent. Thanks for the compliments and for the question. So what I meant for sparse data is that thanks to the approach of virtual population and therefore, for example, no digital twins, is that we can use sparse data set, therefore that they are not complete and they have indeed missing values, as I showed also in the tables. And for some parameters, I did have few, actually half of them was missing. However, I feel like in order to be still reliable, not all the parameters need to must have missing data, otherwise it will be pretty difficult. I feel like in my data set, the volumes, the ejection fraction were complete, and I think that was really important to have. But I think we can, since we are looking at the mean and standard deviation, I think we have the room to have some missing values, which at the end, as you mentioned, is more realistic in the clinic. Because, yeah, it's really difficult to have a complete data set. So a quantity to define sparse, I cannot say it, it doesn't come to my mind right now. But in my data set, yeah, it was pretty sparse. I was missing quite some data, but at the end we did get nice results. So I think that was not influencing too much.
Yeah, because in relation to that, I can imagine that it's easy to find a marginal distribution, so an upper and lower bound of one single parameter. But getting correlations between parameters and dependencies might be harder. How did you solve that? Because you did solve it.
Yeah, we also checked for the correlation at the end. However, when I applied Bayesian inference in the first place, we considered the measurements as independent because it's more it's the easier at the first step when you do a Bayesian inference is that you have to start with an assumption, and usually it's the one of independencies. However, we did get correlation
afterwards
that was matching the one of the clinical data.
There is correlation and dependencies in your model, or not?
Yeah, there is. Yeah, indeed, we do have exactly in the model first, but also in the data. So I think they all come together. So next, if I would start this project, considering the things that I said before, would also be the one to consider the joint distribution, or to take into account the relation that we do have.
Exactly, I think a strong argument for your approach and the feasibility of your approach is that you are able to put in dependencies, which you cannot do if you have a lot of sparse data. So that's a strong point, I think, from that perspective. But then you need a good model. And then I go to the model, and you were completely in favor of circuit depth, of course. And you also had some strong arguments why that would be the best model for your research question. But then I was a little bit confused when I looked to your cover of the thesis.
Yeah.
Because then one part of the heart, I see there all kinds of triangles. So that is actually a spatial discretization of a finite element model. So do you imply that you might, for your research question, also need some finite element modeling? Do you envision a role for that?
That's a good point. That's also what I realized when I put the cover, that at the end, when I was using CircAdapt, we have a 0D and we have the assumption of the spheres, as you know. So this is not the type of art with which I work during my 5 years. And the side in this is discretic, but that was meant to be for the virtual patients, so that it gets from virtual to real. But of course, I think 3D modeling, it's really important. It's really good modeling to use. However, they are pretty complex, and they take time computationally. So I feel like for the type of study that we wanted to do, so mechanistic and for making a hypothesis, and also first and fast, also in silico trials, I think 0D models are really nice. However, 3D, of course.
Yeah, because one reason that I can imagine that you need it for is, for example, you use all kinds of strain patterns. But they have a quite low spatial resolution because it's local, some average or something like that. Have you ever benchmarked that against high fidelity finite element models to be sure what you observe, that you understand what we observe?
I haven't thought about using 3D modeling. However, we have the iconal model, which has been going quite a lot, especially also in our department. So I think also that would have been useful to use, to check. However, in our department, that was also used to better capture the activation times also for the Purkinje fibers, so that we were really sure that the time of activation that we were obtaining was realistic, and then putting in the model.
So you use it for us.
Exactly, yes.
Thank you, Professor Huberts, for your opposition. Dear candidate, Ms. Manetti, the time appointed for the defense of your thesis has passed, and the degree committee will now withdraw to discuss the quality of your thesis and the way you defended it. And I ask you and your company to await the results of our deliberations and our return in this room. With that, I suspend the meeting.
All right, please.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side. 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if there's questions that you've got, go the extra mile and that. On the line, I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile. Long road to the south side, 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if there's questions that you've got, go the extra mile and that. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Hit the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. And even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown. To the south side, 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if there's questions that you've got, go the extra mile and that. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if there's questions that you've got, go the extra mile and that. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile.
Proviamoci. Ok, pronti?
Please be seated.
Ms. I reopen this ceremony. Ms. Manetti, the degree committee here present has assessed the quality of your thesis and the way you defended it. And in view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. And your promoter, Professor Lumens, is authorized to confer upon you this academic distinction in accordance with Dutch university custom. And I invite your supervisor to now take the floor.
All right, please.
But first, a question. Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
I promise.
Good. By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Claudia Alessandra Manetti, the degree of doctor, and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee and affixed with the official seal of the university.
Please be seated.
Thank you, thank you.
Well, okay. Allora, Dr. Manetti, dear Claudia, it is with great pleasure and honor that I congratulate you, also on behalf of Tammo and Nick, also your supervisors. And I'd like to extend those congratulations to your sister, Francesca, your parents, Mama and Papa, and Andrea, I believe we never met. Congratulations. You must have been nervous, I guess, and super proud, and you should be. And all the friends who traveled here and also online, I'm sure there are people online following in the live stream. Well, here she is, Dr. Manetti, and I can tell you they are super proud. And I take the opportunity now to also quickly thank all the people coming here, the opponents from Leuven, Eindhoven, and Delft even, which is, I think, the furthest away from Maastricht. Yeah. So thank you for being here and making this a great discussion. But Claudia, well, some stories, you know. Your adventure began in 2020, the famous year, when you made one of the most courageous decisions of your life, I think. And you left everything familiar. Milano, Monza, maybe I should say, your friends and family, to join our group as part of the EU-funded Marcy's project. And you did this not during normal times, of course, because it was at the peak of the COVID crisis. Pretty tough. For someone as social as you are, this must have been very overwhelming and super frustrating, and yeah, what else should I say about it? So I deeply admire that you took this challenge during the most uncertain period ever. And you were building a new life in Maastricht while the world was in lockdown, trying to create the social connections that came to you so naturally as you did in Eindhoven before, and also back in Italy. I can imagine there were some moments when you must have asked yourself and wondered, what am I doing here? More than once, I think. We talked about that as well, and why did I choose this path? But you never gave up. You persisted, and you were determined. What I especially appreciate, really, is that when things became really difficult for you, you had the courage to reach out and ask for help. You could also not hide it. As an Italian, your body just doesn't lie. And you were honest about your struggles, your insecurities, your frustrations. And that strength to be vulnerable, Claudia, is something I deeply admire. And it not only helped you navigate those PhD challenges that are quite typical but still tough, but it also made me a better supervisor. And I'm very grateful for that. Throughout this journey, you could count on a firm foundation, your family. So even from Milano, and you talked a lot about that, they found countless ways to support you. Your sister Francesca was really traveling a lot with you and became your most dedicated visitor, I understood as well, joining your adventures across the Netherlands. And your parents were always there with practical help, moving, because you like moving, I don't know why. And also emotional support, of course, reminding you of your strength during the toughest moments. The way you speak about their support in the acknowledgements chapter of your thesis shows not only how much they love you, but also what a grateful and grounded person you are. In some words, I would describe you as social, polite, eager to learn, talented, humble, and also a bit naive sometimes. And I'd like to share a story that perfectly captures who you are, both as a person, as a researcher, and I also want to. You already know? Yeah.
Maybe I know. Let's see if it's the same.
Yeah, there was a choice indeed.
There was a choice. Yeah.
But I chose one because we attended several conferences together. We went to Porto, I think, Berlin, Barcelona, probably more, but I couldn't really reproduce that. But there's one story that I particularly want to share with everyone here. It was 2023, not so long ago, and we went to EACVI in Barcelona. It was a massive conference, for you to know. It's really a big conference, 5,000 people, mostly clinicians, which is quite intimidating for a young non-clinical researcher like you at that moment. And you worked through the Christmas holidays to submit the abstract, you remember? Yeah. Which was quite tough, but it was rewarded in the end. When you got accepted for an oral presentation, you remember that? An oral presentation, what that means? Which is really an achievement. We were all excited. And that's already a significant achievement. But at the conference, when the conference was approaching,
like 1 week before.
Yeah, 1 week before or 2 weeks before, you suddenly seemed very stressed about the fact that you had to upload your presentation. You remember? So early, which seemed very unusual for us. And when I asked you the third time maybe, or maybe even more, what kind of session you were presenting, and you said with complete certainty, well, it's a regular oral session, but with a rather boring title or something, you said. It says something like Young Investigator Award Basic Science, which is a bit strange. And I looked at you in total disbelief, but your expression told me you had absolutely no idea what you had just achieved. Huh? You were selected, more than 500 abstracts are being submitted, people do grade that, and you're with the top 4 or 5 with that. So that's incredible. From that moment, you spent every minute perfecting your presentation, and with our whole team helping you also to make an incredible story. You were nervous, but Claudia, you were so prepared, like today, so determined, you absolutely rocked the stage, absolutely. And Ahmed and I witnessed that, and we were very excited at that moment. You became the runner-up for the Young Investigator Award, which really is, with the work we do, is quite exceptional, and that's an understatement. So that's you, Claudia, talented, humble, and wonderfully naive about your own achievements sometimes. You started like a rocket, the rocket that builds momentum slowly, but then it accelerates to very good heights, reaching levels that will take you far across Europe, maybe the world, or maybe even in space. So this diploma represents far more than your scientific accomplishments. It proves your courage to take risks, your resilience and ability to grow in difficult times. What a pleasure and honor it was to be your supervisor, really. And I wish you and your family the brightest future. Now it's time to close the first chapter of this day and to see where the next one leads us.
Thank you.
Thank you, Professor Lumens, for a very nice laudation. Dear Dr. Manetti, also on behalf of the University of Maastricht, I congratulate you with the degree you have acquired, and I hope you can celebrate this important day, perhaps one of the most important days in your scientific career. I extend, of course, my congratulations to your parents who have worked so hard. And, of course, your supervisors, Professor Lumens, Professor Delhaas, Dr. van Osta, and, of course, your parents, family, friends, and colleagues here present and online. And I would like to thank the members of the opposition for all their hard work, and, of course, the Padel and the technical support team who made this ceremony and the streaming of it possible. So I'm about to close this ceremony, and then we go off to the reception. We will leave this room first and then go to the foot of the stairs where we make a picture, and perhaps a second picture with your parents and family on it. So we need a photographer. And the rest of the audience, I would like to ask not to come all together to the foot of the stairs, but already go to the reception room, which is in the garden, I think, in the garden. And then when you ask yourself, when can we then congratulate the young doctor, it's quite easy. You watch us, we go first, and then you follow. Having said that, I close this ceremony.
Later.